My dear postgraduate students, a good day to all of you. We shall continue with the grossing of the organs. And the topic for the day is the spleen. Without much ado, I shall go into the topic proper. This is one saying that I like a lot. Do the small things properly and the big things will take care of themselves. When it comes to the spleen, for that matter any organ, we should always think of the subheadings, and the subheadings will take us to the answer. These are the fundamentals that we should be having in mind whenever we discuss an organ or face the eventualities in the examination. There are certain dictums, however, which we should remember. First and foremost, do not make histological diagnosis from gross specimen. For example, non-Hodgkin's lymphoma, small cell type. The label it carries is post-histology or post-biopsy wisdom. Sometimes there might be a tag attached to a wet specimen, or there will be a label to the mounted specimen. Please do not go by it. Once we identify the organ or the lesion, the questions thereon will be different. So please do have these dictums in mind. Anatomy. After all, pathology is supposed to be abnormal anatomy and physiology. And this is a beautiful picture taken from McGraw. The author is the signature below. We are supposed to mention the size of the organ, the weight, the borders, color. What are the various impressions? Impressions means the pressure formed by the adjacent organs, the development and the accessory. If you were to take this one, I would like you people to kindly appreciate that it is about the size and shape of a closed fist. And there is an entry of an artery and an evolution of a vein. Obviously, there will be a depression which is called the hilum. The spleen is identified by means of its sharp borders, and there will be certain depressions which are called the notches. Again, this is one organ which will be having a purplish tinge, which is very much brought out in this diagram. The purplish tinge is because of a venous stasis. Understand and apply. Obviously, the gross and the microscopy go hand in hand. And I always say the practicals and the theory also go hand in hand. This is a diagrammatic or a schematic picture of the spleen, which you people can make use of when you take the classes for the undergraduates. There is a capsule, and then there are depressions from the capsule called the trabeculae. These are incomplete, and you will also be seeing them some areas which are somewhat reddish in color called the red pulp, made mainly of the sinusoids or a network of sinusoids. And there will be relatively pale areas which are called the white pulp, where the lymphoid follicles are seen. So these are the fundamentals which we people should remember: capsule, trabeculae, red pulp, white pulp, hilum obviously. And when you come to this one, I would like you people to go through these labels if time permits. But what I am interested is the sinusoids. The sinusoid is a lesser version of a capillary, and there is a network of these sinusoids which is of paramount importance. There is also an ancillary arteriole that is found, and it will be going via the trabeculae into the pulp, and we used to call it a trabecular artery or a trabecular vein. So this is an artery, for example, and it is traversing the follicle as such. And these are all the areas of the red pulp. When we talk about the spleen, we should remember certain fundamentals. One, it is a lymphoreticular organ. When I say lymphoreticular, it can be lymph node, thymus, bone marrow, spleen. The function is it removes the senescent or the old RBCs. It is also a fundamental mononuclear phagocytic system, as a result of which phagocytosis is one of the most important activities. Last but not the least, you find that antibodies are being produced by the lymphocytes. Lymphocytes will ultimately become the plasma cells produce the antibodies. So please do have this in one corner of your mind. And coming back to the fundamentals over here, it is located in the left upper quadrant of the abdomen. It is fist shaped and it is also the size of the same. The dimensions are better explained in the next diagram, but for the time being we shall remember that the impression of the 9th, 10th and the 11th ribs can be seen. These cover the spleen. Normally it is not palpable, it has got a purplish tinge as I had explained. The hilum is a point of entry and exit. Splenic notches can be seen and also the impression of the ridges. Location is left upper outer quadrant. So these are the important things, because the question to you people will be, how do you say it is spleen? You are not going to be given a normal spleen, but it can be an organ of enlargement. Obviously the question will go thus. And this is the rule of the spleen, which I would like you people to kindly remember. 1, 3, 5, 7, 9, 10 and even 11. Look at this one. An easy way to remember the anatomy of the spleen is this. And thanks to Wikipedia for providing me with this information. Let us see how it is useful. The size is in inches. 1 into 3 into 5 inches. 1, 3 and 5. Weight is 7 ounces. 7 is over here. And it lies below the 9th, 10th and the 11th ribs. 9, 10, 11. And the main axis is formed by the 10th rib. Regarding the neurovascular supply, the artery is a splenic artery, vein is a splenic vein, lymph is the celiac node and innervation is the celiac plexus. Quite easy for us to remember, unlike the other organs to which we shall be going at a later date. So please do remember this 1, 3, 5, 7, 9, 10 and 11. That will be the rule. And coming to the weight of the spleen, it is around this 140 to 160 grams. But sometimes it can be as low as 100 grams and it can extend up to 300 grams. Less than that is supposed to be an atrophy of the spleen, which we shall see can happen because of autoinfarction. A beautiful picture. Whenever there is any organ that is given to you, they will ask you to hold it in an anatomical position, and that is how it is being held. So I am able to see the upper end and the lower end, and I am finding a sharp border. There is a hilum that can be seen. If I go through the specimen, there might be notches or depressions that can be seen. And also the cut surface is supposed to be slate grey in color. It is somewhat greyish white because the specimen is fixed in formalin. So please do remember this. What are the various rules? How do you remember? And the anatomical position of the spleen. This slide is of importance to us because a case of portal hypertension or an assembled such case can be given to us for the autopsy, or this is one of the most common questions asked in the viva. What are the sites of portosystemic anastomosis? This you shall know by heart and rattle off. There is an anastomosis at the lower esophagus, rectum and anal canal, umbilicus, bare area of the liver, retroperitoneum, and patent ductus venosus. It is not arteriosus, which is very rare. And these are the portal components and the systemic components. Please do by heart. It is not very difficult, but it is worth its weight in gold. This is what we are seeing. What are the sites of portosystemic anastomosis? So this is the bare area of the liver, the lower end of the esophagus, and at the rectum and the anal canal, and towards the hilum of the kidney, then the periumbilical region, and portovenous anastomosis is not shown in this picture. So there are 6 sites where there will be portal systemic anastomosis. Please do remember them, and the components are given. And there is also another important thing is the normal anatomy of the portal vein and its branches. So there is a hepatic vein over here, there is a portal vein. There is a dual venular drainage in and around the liver, which we shall have in mind. The splenic vein is formed from here. So obviously whenever there is going to be a cirrhosis or any form of obstruction, there is going to be a damming up of the blood, dilatation of the sinusoids, and there is a congestive splenomegaly. The other things again I would like you people to read. This is a beautiful diagram once again picked up from the net. Now there are certain things that we should remember about the spleen. What happens in a case of portal hypertension? Before I go further, you are able to appreciate the splenic notch. Another thing that is characteristic of the specimen is the capsule is stretched and shiny. I can see the reflection of the light. Also, there are some pale areas which might be indicative of adhesion or perispinatus, which is called as sugar icing, classical of the spleen, hyaline perispinatus. So there are areas of pinkish hue or color that I can see. There can be an enlargement in the splenic size and weight. It can go up to 1000 grams or even more. And this is a esophagogastric junction in which I am able to see the dilatation of the venules, portosystemic anastomosis, and then there is a dilatation. Obviously these are all indications of a bypass. Whenever there is going to be a disorder such as a cirrhosis of the liver, there is going to be a narrowing, and so there is a bypass that is created, and one, there can be dilatation of the blood vessels, there can be bleeding. Secondly, you find that these products do not enter the liver, so they are not detoxified, and the patient can go in for a hypernatremia, increased amount of nitrogenous waste products as well as the retention of sodium. And this again is a classical example of the sugar icing that I had mentioned earlier. There is a pinkish hue and an adhesion that can be seen. Neoplasms and non-neoplasms. These will be the basic subheadings under which we will decide or define the organ pathology. First, we shall see the non-neoplastic lesions of the spleen. As I told you, there is a capsule which is not very much adherent, but it is there. And then the parenchyma is homogeneous. I am not able to see a string sign that is over here, which is classical of CVC of the spleen. And it is somewhat paler in color, and it could be due to amyloidosis. It could be better brought out in the mounted specimens where it is pale, pinkish white in color. How we should describe this? Glassy, waxy, pale, homogeneous. These are all the characters of amyloid. Whether it is sago or lardaceous, we are all one. Picture courtesy goes to Alamy. You can see them in the background also. We should not steal and we should accept their contribution. This is a case of a lardaceous spleen. I use a mnemonic. Lardaceous means lace-like. So there is a network around the sinusoids in a lace-like manner. This is called lardaceous spleen. Whereas sago means the sago grain. It is a kind of a grain. It has got this kind of an appearance. So it is called a sago spleen. Both of which are classical of amyloidosis of the spleen. I hope you are able to differentiate between the two. And look at this over here. There are multiple nodules. You may get a specimen of the spleen. So again, the hilum is over here. There is a capsule. The cut surface is showing multiple small nodules uniformly distributed throughout. So what are all the differential diagnoses you can think of? Pause for a minute. See whether you are able to recollect the differential diagnosis. Tomorrow this might be a specimen. As I told you earlier, do not make histological diagnosis, rare histological diagnosis on a gross specimen. Non-neoplastic disorders continued. Storage diseases, liver, spleen, these are all organs which are commonly affected by storage disorders. Gaucher's disease is one. So in this again I find that the organ is pale. Any of the accumulations, the organ will turn out to be pale in color. It is enlarged, the capsule is stretched, and it is homogeneous if there is no infarction. Microscopically, you find that the cytoplasm will be having a crumpled tissue paper appearance. Basically, it is a lysosomal storage disease, and it is a university question for you in itself. The different types of Gaucher's disease you people can go in. And whenever I use the word Gaucher's, automatically there has to be a name and pick. And in this I find foamy cells with multiple small vacuoles. Sphingomyelin is being accumulated. So either of it, this can be a Gaucher, this can be a name and pick. At the most I can say it has a differential diagnosis. And as I told you earlier, this is what we find in the museum. Many of the specimens are labeled, but then that label is a post-biopsy wisdom, as my professor Dr. Narasimhan used to say in JIPMER. Differentials would suffice at this point. So this we have already seen, and the sampling. Obviously, the specimen of the spleen is brought to us as a total splenectomy. Partial splenectomy, biopsy, etc. are not conventional. They are not advised at all, not recommended. The reason is very obvious. Because of the high vasculature, intruding into it is going to cause profuse bleeding, which will end up with splenectomy anyway. That is why we get specimens with splenic rupture. And when it comes to the sampling, this is how you people should do. Normally in a spleen, particularly if it is going to be a lymphoma or a tuberculosis or a metastasis, areas of infarct, etc., 10 to 12 bits are given across the entire cut surface. As mentioned earlier, areas with different kinds of a texture or a color will have to be sampled. Whenever there are areas of hemorrhage and laceration, it should be. Fibrosis, cystic lesions, thickening of the capsule, any other structures such as the adjoining nodes or sometimes an accessory spleen. So this list we will be having in mind, because the common question will be, where all will you take the bits from? And as I mentioned earlier, have the differentials in mind. Earlier also I had shown you this picture under this amyloidosis. So it can be like this. So it can be leukemic deposits, it can be a lymphoma, it can be a Hodgkin's, it can be miliary tuberculosis, multiple infarcts, or a sago spleen itself in amyloidosis. In all these conditions, I find that there can be multiple nodules. So from this, it is not possible to make a diagnosis of benign or malignant, neoplastic or non-neoplastic. Splenic rupture. As I told you, accidental rupture, traumatic one, or sometimes it is forensic, a stab injury, etc., can result in a tear of the parenchyma and the capsule. And what we will be seeing will be pools of blood. So What are all the indications for splenectomy? Any splenic rupture, it is a surgical emergency, it has to be removed. Lymphoma, sometimes we do it for staging and therapy. Multiple infarcts, we'll have to do it. Portal hypertension, rarely it is advised. Hypersplenism, refractory hemolytic anemia, as in the case of spherocytosis. ITP, tumors, parasitic cysts. These are all some indications of splenectomy. Please do have it in mind, and there should be a logical sequence with which you people should answer. So look at the tear over here and the hematoma that is there, and obviously the spleen itself is enlarged. And when we do the grossing of any specimen, it has to be cut in slices of 1 centimeter. We are not supposed to wash the specimen, instead we can mop it with filter. Sometimes an imprint cytology is advisable. We may get a rare diagnosis even before the processing is over. Bits can be given from the various areas as we had mentioned. Also anatomically from the capsule, the hilum, lymph nodes and accessory spleen. This is a picture of a couple of accessory spleens that could be seen. An easy way to remember, I had shown you, go by it. And there is a purplish hue that is present. Pathology and appearances go hand in hand. A lot of appearances are there. Mirror image appearance, for example. And when it comes to the spleen, look at these. An agu cake, miliary or millet seed-like, amyloid, abscess, infarct, geographic infarct again, slate grey appearance, hypersplenism. Look at the plethora of pictures that the spleen can present. And agu cake is this one, which is classical of, tell me if you know. So I am finding that there is a splenomegaly along with areas of hemorrhage which is somewhat turning reddish brown or brownish black, resembling this cake, hence the agu cake appearance. Multiple deposits can be lymphomata. It can be CLL or SLL, leukemic deposits. And as I told you earlier, never give a diagnosis of non-Hodgkin's or Hodgkin's, and still worse, do not give a further histological diagnosis. Leukemic deposits can be seen throughout. And this again is a case of a lymphoma of the spleen. And whenever you see a specimen, you please analyze, and there is a lesion. Please do analyze. Is the lesion single or multiple? In this case, it is multiple. Is it focal or distributed? It is uniformly distributed. Is it solid or cavitary? You find that the lesions are solid. So these you people can use to describe your vocabulary for the description of the specimens. And this is what I had seen earlier. You find that it is similar to the agu cake that we described, brownish black in color, and there is a massive enlargement of the spleen. Massive enlargement. You can palpate it in the right iliac fossa. No mistake in my words. Right iliac fossa. It crosses the umbilicus, goes up to the right iliac fossa. And this is a case of a massive splenomegaly. My professor of medicine, Dr. M.S. Ramchandran, used to say, remember the 3 M's: malaria, myelofibrosis, myeloid leukemia. In addition, a hairy cell leukemia is one of the favorite choices. Please do remember. But then you find that there can be a splenomegaly in almost any condition. Do not give typhoid as a cause. There will be a splenomegaly, but not conspicuous. So look at this. There is an umbilicus, and I find that there is a swelling from the left region crossing the umbilicus, and it can be palpated in the right iliac fossa, and it is made out by means of the sharp borders. If you are lucky, you may be able to palpate a notch. So the causes are here. Again, a radiological picture of the same, crossing the umbilicus, going into the right iliac region. Myeloid leukemia, myeloid fibrosis, hairy cell leukemia, lymphoma, malaria, Kala-Azar, storage disorders, as we had seen earlier. Chronic venous congestion, fairly a good answer. Non-neoplastic, again we are continuing. There can be a solid lesion or a cystic lesion. And whenever we see a cyst, it is supposed to be a hollow lesion that is lined by an intact epithelium. That is called a cyst. Otherwise, it can turn out to be an abscess. And whenever we say use the word abscess, we will have to mention the inner structure of it or wall of it. So this is a radiological picture of the spleen, and in which there is a large abscess that is almost replacing it. So it can be parasitic, it can be non-parasitic, it can be true or pseudo. Look at the spleen. So I find that there are multiple cystic lesions. The inner wall is quite smooth, so there is multiple cystic lesions. So what can be the differential diagnosis? We shall be seeing. Look at this specimen. Here I find that it is ballooned out, stitched and shiny, whereas here it is dull, probably more solid. And when it is cut open, I am able to see multiple cystic locules. So there is a tender coconut-like appearance which is classical of a hydatid cyst. There are two variants of it which you people should remember. One is called unilocularis, that is most common. Another is multilocularis, Echinococcus granulosus. And this is what you people see. This is a pericyst that is there, and then there is the inner wall which has got a laminated appearance. Then there is a germinal epithelium from which there can be the brood capsules. Sometimes grossly it is felt as a hydatid sand. The scoliosis will be refractile, and we will be able to see them in our histology slides if we are lucky. This is what I had been mentioning. So this is also a lesion, but there is no intact epithelium over here, and it is obviously an abscess. A beautiful specimen from the Brown University. Inner wall is ragged, so it is a septicemic or a pyemic abscess. Not very common, but it can be found in Pseudomonas infections and also in cases of immunosuppression. Patients who are having HIV, they may manifest with a lung abscess with empyema as well as a splenic abscess. So these are all the features that I had mentioned over here. Rarely there can be even fungal etiology such as a mucormycosis. And when it is coming to a cyst, it is usually smooth, regular, unilocular or multilocular, and in this case it has got a typical tender coconut-like appearance. Incidentally, it is not the spleen, it is picked up from the liver, but only to highlight the appearance of the hydatid cyst. An infarct. Is it clear? An infarct can be an area of localized necrosis caused by the sudden, complete and irreversible occlusion to the vascular flow. And this is what I had mentioned earlier. Whenever we see multiple nodules, this is fairly regular, so it need not be an infarct. But if it is going to be irregular like this, I will have to think of multiple abscesses or infarcts. Multiple infarcts can be happening in conditions such as a sickle cell anemia, where there can be repeated obstruction. And look at this one, a typical white infarct that you people see, which is wedge shaped. The area beneath the capsule is spared, and this might be the point of occlusion, the branches of the arteries, and hence you find this kind of an outline in a white infarct, a triangular or a wedge shaped infarct. And pyemic is also an abscess and an infarction that is seen. Sometimes the differential diagnosis can be metastasis or lymphomata. So this can be a differential diagnosis of a lymphoma or a sago-spleen that has to be ruled out. And there can be some non-neoplastic, that is a amyloid that I said. Geographic infarct is somewhat different. Look at this. Again, multiple infarcts are there. So the patient is having repeated obstruction. It can be because of lymphomata, or it can be because of metastatic deposits, or sometimes very frequently in a case of a sickle cell anemia. That is why there is a repeated infarction, and it will be going in for an autosplenectomy. So these are the different types. But look at this one. I am finding ragged, irregular areas of infarct which are all coalescing together. which are all joining together. Ultimately, I find that there is an irregular map-like outline, and this I used to call a geographic infarct. It resembles a country in a world map or a continent. And this is the case of a chronic myeloid leukemia with massive splenomegaly, and also there are areas of infarction. So I hope you people are able to appreciate the different types of infarcts that could be visualized and appreciated grossly. And coming to the tumors, there can be vascular lesions, which can be a hemangioma, extremely common. Hemangioma, vascular malformation, and then it is not very well defined. But then I am able to see it is not capsulated or demarcated. It can be a hamartoma, mainly from the red pulp, angiosarcoma, and then a hematoma in a case of a blunt or a sharp injury. So these are all the vascular lesions you people should be having in mind. And look at the hemorrhage over here. You find that there are dark areas of recent hemorrhage, and it is showing some kind of a degenerative change also. Whereas in this, it is again irregular vascular. This can be an angiosarcoma. But be careful, these are all post histology wisdom. And whenever I see a specimen of a spleen or a lymphoma is given to me, I cannot guess in what direction the questions will go. And this is a picture of an Ann Arbor classification of the Hodgkin's lymphoma and the staging. So we people should have anything in mind starting from the etiology up to the staging, or even an autosplenectomy. That is why it is said, medicine is a science of uncertainty and an art of probability. William Osler, a famous physician who has said that as is your pathology, so is your medicine. Mercy.